All right. Well, thanks everyone for joining. Before jumping into what I know is going to be a very interesting presentation, I'd just like to begin by acknowledging the traditional custodians of the land on which we are meeting today, the Wurundjeri people of the Kulin Nation, and pay our respects to elders past and present. We extend that respect to any Aboriginal Torres Strait Islander person here today, and we recognise their continuing connection to the land and waters, and acknowledge that sovereignty was never ceded. Okay, so now onto our presentation for this morning. I'm very pleased to introduce you to Dr Meredith O'Connor, which I know all of you know very well. Thanks, Meredith, who will take us all through the extraordinary program of longitudinal research that we run through the MCRI and the supports that the MCRI LifeCourse initiative now provide us all. Meredith and I have been friends and colleagues for many years now, starting back in 2008, where she commenced her Doctor of Educational Psychology within the Australian Temperament Project. She's gone on to build a stellar career in large-scale longitudinal studies, which has culminated in taking up a senior leadership position to build the Melbourne Children's LifeCourse initiative. This role includes designing and managing central infrastructure to support cohort excellence, and also to facilitate what is an emerging and vibrant culture of cross-cohort research on campus. She also contributes to the design of some of Australia's seminal longitudinal studies, including the longitudinal study of Australian children.
So it's like consider reclassifying if coronary artery calcium.
Where she has been a member of the scientific advisory group since 2018. So I'll hand over to Meredith now to lead us through what will be a comprehensive overview of the LifeCourse initiative and what it offers us all on campus now and also beyond the campus. So thanks, Meredith. Look forward to it.
Thanks so much for that introduction, Craig. As Craig mentioned, my name is Meredith O'Connor, and I am a Senior Research Fellow and also the Program Lead with the LifeCourse platform for the last few years now. I'd normally be chairing these sessions, so it's actually lovely to switch places for once and share some of our thinking in this area. And as Craig said, what I'm going to focus on today is some of the research opportunities that the LifeCourse platform provides and what the LifeCourse infrastructure team has been working on to make it as efficient and straightforward as possible for researchers to be able to engage with these cohorts. But what I'm particularly wanting to focus on today is the benefits that can come from working across cohorts. So where there are those opportunities to work synergistically by drawing cohorts together for analysis as an additional value add beyond that traditional approach, which is to do the deep dive in one specific cohort. So indeed, there are some things in life that are better together. I can vouch for bacon and eggs on my Sunday brunch yesterday, spaghetti and meatballs, or one of my all-time favourites, black American coffee and donuts, which is just a winning combination. And again, that's what I'm going to be talking about today, is where are there these opportunities to work across cohorts and to draw them together in a way that the product is greater than the sum of its parts, and we can get that synergistic value and that joining forces to create additional benefit. But first, I want to go right back to basics and consider why longitudinal studies are such an essential element of our scientific landscape. Then I'm going to go into some of these issues around multi-cohort research and where the benefits for research can arise, and the types of scenarios where working across cohorts can be very generative and can allow us to go out into terrain that wouldn't be possible within the limits of any one existing study. And then I'm going to talk to how the LifeCourse platform is making this not just a good scientific idea in some scenarios, but also a feasible, logistically possible thing to do. Before we get going, though, I do want to acknowledge that the LifeCourse platform is the product of a lot of hard work from a lot of different people, including Craig, who was the founding investigator of the platform 10 years ago. In fact, we're coming to the LifeCourse 10-year milestone, which is really incredible. And the work I'll be talking about today also particularly draws on the partnership between LifeCourse and the CEBU statistical group at MCRI, which has been a particularly generative and important part of this interdisciplinary platform, where been able to take the perspectives of applied researchers like myself and Craig and combine this with the methodological rigor of the CEBU statistical group. And that's been a particularly important strength for the work that I'll talk about today. When we think about the major challenges that are facing child and adolescent health, even though I'm in my office today, I'm on campus at RCH Hospital, there's certainly a recognition that many of those significant challenges are impacting on large numbers of children and young people who never actually set foot into the hospital setting. Concerns like mental health challenges, for example, that's my area of speciality and focus, which impact on such a large number of children and young people out in the community. Similarly, immune-related conditions like allergy and asthma, with prevalence on the rise, and risk factors like obesity that can carry implications for cardiometabolic disease, as well as a range of other health conditions across the lifespan. Common thread running across these health issues is that they tend to have their origins early in the lifespan, and they unfold and play out over very long periods of development, sometimes with observable health issues not actually emerging till much later down the track, even in adulthood. Longitudinal cohort studies present an absolutely vital asset for being able to understand and unpick these early life mechanisms and how those impacts on health and development unfolds over the lifespan. And that's because they're following the same individuals over time, from those early infancy periods in some studies right through to the adolescence and sometimes even adulthood years. And they can observe that emergence of health challenges and strengths as they occur. This includes the capacity to understand some of the influences on health that we would never want to see randomized in a trial. For example, adverse childhood experiences is something that I've looked at in my research, and we wouldn't want to see a trial randomizing out those kind of experiences to children. And beyond these conceptual strengths of longitudinal cohorts, there's also an important pragmatic imperative here. Longitudinal cohorts exist that provide mature, detailed, developmental information that's ready and available for analysis right here and right now. And that's essential when policymakers have a decision on the table, for example, and they need evidence, relevant evidence in the short term. They can't wait around for the 20-year outcomes of a new study. So can provide that evidence that's needed in a timely and an efficient way. Our RCH campus happens to be home to an absolute wealth of these types of existing long-term longitudinal cohort studies, and in particular those focusing on the childhood and adolescent periods. We have 23 core longitudinal cohorts in our LifeCourse platform that reflects over 40,000 children and young people, followed from infancy right through to the adulthood years, and going as far back as the 1980s. So this historical perspective on health and development as well. And these cohorts are absolute diamonds. We cannot overestimate the value of these longitudinal cohorts. They reflect very significant investment from funders who have come back again and again to support waves of data collection over sometimes very long periods, and many times going back out into the field to follow up these children and their families. And they also reflect very significant investments from the individuals involved. The research teams who work incredibly hard to develop such high quality data resources, and also the participants themselves who year after year are engaging with these studies and contributing what sometimes they're quite sensitive health data. So an enormous contribution to public health that these participants are making. The LifeCourse platform was established back in 2013 with the goal of maximising the utility of these data resources and allowing researchers, both internal and external to MCRI, national and international, to be able to engage with these data and undertake research that meaningfully benefits child and adolescent health. The usual way that researchers would engage with these cohort data is to do the deep dive into one specific cohort and to grapple with the nuanced and detailed data that a cohort might have on perhaps their area of specialisation or focus, where there's often very fine-grained measurement in that priority area for a cohort. And that's probably always going to be the backbone of cohort research. I think that capacity to really go deep in a cohort and grapple with the intricacies of that specific data. And that will remain a very important part of cohort research. And this is an example from one of my studies where we've done this kind of deep dive into one specific cohort. And in this case, it was the longitudinal study of Australian children, kindergarten cohort. And this cohort, because of the particular focus on mental health over time, collected detailed data on the internalising symptoms of children that were being followed. So their symptoms of elevated sadness, worries, fears, and repeated assessments of these concerns over each wave of childhood and adolescence follow-up every 2 years. And what we wanted to understand in this piece of work is to grapple with some of that very detailed, repeated data to understand the continuity of internalising symptoms between the childhood and the adolescent period. And in particular, we wanted to illustrate this level of continuity in a way that was straightforward and easily understandable to our policy partners in this work, who are the Department of Social Services. So previous literature had often used trajectory modelling, complex latent variable modelling approaches that can be difficult for policymakers to understand and to relate back to the data that's been collected. We wanted to offer a more straightforward narrative for policymakers to engage with. So what you can see here is the proportion of young people who were experiencing elevated internalising symptoms at each age in adolescence. So at 10 to 11 years of age, 12 to 13, and 14 to 15. And you can see the estimates for girls in red and boys in green. What you can also see is that this has been stratified depending on whether young people had never experienced any instances of internalising problems in the previous childhood period, or whether they had experienced, at least at one time point, some previous internalising challenges. And you can see how substantially different the that prevalence of adolescent internalizing problems was, depending on whether there was this history of childhood challenges. So reinforcing the absolutely critical role of early intervention and prevention, addressing internalizing problems from the early periods of life to lay the foundations for good mental health coming into the adolescent period. And we were able to tell this story to the relevant policymakers we were engaging with this detailed deep dive into this one particular cohort. But there's also challenges in working within just one specific cohort. And one of these is the so-called replication crisis that I think we would all, just as consumers of the news, be well aware of and have seen that flip-flopping that can occur in red wine being good for us yesterday and bad for us tomorrow, and so forth. This failure to replicate findings when a similar analysis is undertaken in a distinct data source. There's also increasing interest in the concept of precision public health, and that requires us to get into these questions of who are we really talking about, and understanding risk processes within very specific subpopulations or periods of the lifespan, or contexts and environments in which risk processes might play out in a different way. And developing that kind of evidence often requires a level of detail or concepts to be covered within the data that we're analysing beyond what's available in any one existing data source. So many complex contributors to the replication crisis, and many strands of this move towards precision public health, but certainly that failure to establish the replicability of our findings can be one contributor, and also the limitations of existing data can constrain us from going into that next level of nuance around who and in what contexts these risk processes might play out. So is there a simple answer here? Can we just combine all the things and throw all our cohorts together and solve all of our problems? Well, of course, nothing is that easy, but certainly it has become increasingly common to work systematically across cohorts in recent years. This isn't a new idea. It's a very long history in developmental science, this concept of can we work across cohorts to meet the needs of certain research questions that couldn't be progressed within the limits of any one existing data. But I think probably in large part due to platforms like LifeCourse that make it much more logistically possible to work in this way, we are seeing that this is an increasingly common approach in developmental science. And our experience in the LifeCourse platform would be that there are certainly great benefits that can be gained from working in this way, where we are able to go beyond what the terrain that we could cover if we were only working within the parameters of any one existing data resource. Of course, no easy answers though, and lots of scientific and methodological and also logistical challenges that can come up in this type of work. For one thing, when we talk about multi-cohort research or multi-cohort analytic approaches, we're not talking about just one thing. There's actually a whole constellation of different approaches that can be used to analysing data across cohorts. One that's quite well known is that capacity to align data elements from different cohorts, for example, align the assessment of mental health symptoms to create a harmonised measure, and then taking the participant data on those variables from different cohorts, appending that into one mega data set that statistical analysis can then be performed on. So pooled data analysis, often called harmonised data analysis or integrative data analysis. So another very common approach with a very long history is replication approaches, where we're undertaking analyses separately, distinctly within each cohort, but we're using an aligned analytic procedure. And then comparing the results that arise from those aligned analyses and considering their similarity or difference. There are focus literatures on each of these specific types of analyses, but what we found was a bit of a sticking point in the literature is this capacity to get a bird's eye perspective across these different analytic approaches, and in particular, where and when you might select one over another, and how to consider the full range of analytic approaches that are available. So in this recent paper, we have tried to be that cocky and provide that bird's eye perspective across this multi-cohort landscape. And in particular, our starting place for this conceptual review was to consider what are the benefits that we're trying to achieve when we go out into this multi-cohort type of approach? What's the underlying motivation, and why are we willing to take on the inevitable additional complexity that comes with working across cohorts? What's the payoff here? One of the key benefits or payoffs that we identified was that capacity to draw cohorts together in a way that helps to build a larger picture. This is particularly relevant if we're grappling with a complex health theoretical model or a very complex health process over very long periods of the lifespan, where no one cohort contains all of the information or all of the data that would be required to grapple with that model. So the idea here is that we could use one cohort to describe the trunk of the elephant, one to describe the tail, one to describe the ear, and then by drawing those findings together narratively in our paper, we're able to do a much better job of reflecting the elephant and discovering the elephant rather than any one aspect that might lead us down some erroneous paths. So this really a relevant approach when we are grappling with those very complex health questions. This is an example from our group from the LifeCourse COVID Wellbeing Program of Research that's currently underway. And what you can see here is the percentage of children and young people who are, whose parents are reporting that they have elevated symptoms of worries related to COVID-19, so extreme fears about infection and so forth, negative mood states, so again, those internalizing symptoms, sadness, worries, anxieties, adverse economic impacts for the family, such as job loss, and so on, and also positive life changes for the family, things like being able to spend more time with each other. And this is data collected during the acute phase of the pandemic, so 2020 into that early period of 2021, when, as we would all like to best forget, I think we were going in and out of lockdown and still very much grappling with that constant disruption and wide-ranging limitations and restrictions. We pulled together data from 7 different cohorts And these cohorts are unusual and helpful in coming together because they vary so widely in their socioeconomic characteristics. So we've ordered these cohorts from vitality on the left in purple, the most advantaged cohort, and then step by step increasing in level of disadvantage, right through to right at home, which is a targeted sample of families facing high levels of social adversity. When we analysed the data from across these cohorts, what we could quite clearly show is that as the socioeconomic disadvantage within a sample increased, so too did the prevalence of adverse outcomes like worries, moods, economic disruptions for families. And then on the other hand, in the other direction, we saw that opposite trend for positive life changes. So by bringing these cohorts together, we were able to illustrate those inequities in the distribution of these indirect impacts of the pandemic. And this is beyond what we would have been able to understand from any one of these cohorts, which each on their own has fairly limited socioeconomic variation. So we were able to get more to that elephant rather than just the tail or just the ear. Another key benefit for working across cohorts that we identified in our review is the capacity to explore whether findings are similar or different across different cohorts. Similar or different being a matter of degrees rather than qualitative, like these two little fellows here, almost the same, maybe not quite. And sometimes the focus behind this kind of exploration is on speaking directly to those issues around the replication crisis and really being wanting to be able to inform the replicability of the findings that we're putting on the table, and being able to be much more confident in what we're putting forward if we can see that it is replicable in other similar cohort studies. At other times, the focus here is broader and more around theory building. For example, when we're looking at the transportability of an effect, does an effect play out in a similar way in another cohort that differs on some feature of interest, like the cultural context or the geographic context of that cohort? So in that case, we can undertake similar analyses and learn something about whether an effect plays out similarly in a different context. And there are a wide range of analytic approaches that can be used to get to these kinds of issues, like, for example, replicating analyses distinctly within each cohort and then comparing the results that are generated. And this is, again, an example from our group, and here we've used that approach of replicating analyses distinctly within, in this case, two different cohorts and then comparing the findings. Here we were interested in two different contexts: Australia, where we used the longitudinal study of Australian children to capture, and the UK, where we drew on the Millennium Cohort Study, which is a very similarly designed longitudinal cohort in that context. What we wanted to do in this piece of work was to do some basic descriptive epidemiology to understand the natural history of mental health competence. Mental health competence being those psychosocial skills, assets, capacities that allow a child or a young person to go beyond just perhaps the absence of mental health disorder to get into that territory of thriving and of having the skills and capacities that are needed to operate in the complex social world that we now are all living in. So we described that prevalence of mental health competence using a aligned measure across these two cohorts from 4 to 5 to 14 to 15 years of age. And we did so separately for girls in red and boys in blue because of well-established gender differences that we've observed previously in Australia. And what we found when we plotted this out was that well, first of all, you can see that in absolute terms, the proportion is slightly higher at each age in the UK cohort. That's probably just a reflection of the fact that at each of those age bands, the Millennium Cohort Study tended to cluster at the older end of that band. But what's really striking from these findings is how similar this pattern of prevalence is over time. So we can see that gradual increase in parents' report of these skills, and then perhaps a slight dip in the mid-adolescent period. So suggesting that across these two settings, there are common developmental pathways here, or at least in regards to how parents are viewing this progression of skills for their child. And as they're coming into the adolescent years, perhaps parents picking up on the fact that young people are face a real step up in terms of the social complexity that they're engaging with, the wide range of social contexts that they're challenged to operate in, and the level of independence that they're increasingly expected to take on. So lots of chances for missteps during that period that parents might be reflecting here, but nevertheless, that leading probably to greater mastery of these skills later down the track. Third and final benefit that we identified for working across cohorts is the capacity to gain greater precision. So when working with cohorts, I think anyone working with cohorts has had that experience where you just start butting up against the limits of the sample size that you have available. Long-running cohorts, typically because of the resources that are involved in that long-term tracing and tracking and following up participants, are constrained in the number of participants they can keep engaged in the study. And so when particularly we're working with exposures or outcomes that are lower prevalence, this can be a real barrier to generating estimates that are precise enough to be meaningful and useful for informing public health research. And in that case, we're often less precise in the kinds of conclusions that we can bring forward from that research as well. I think we've all read implication sections like this, stuff and things should come out of this research. So here, when we're working across cohorts, we can benefit from approaches like pooled data analysis, where we're essentially creating a larger sample size for analysis by combining the data from across 2 or more cohorts. This is again an example from my work and work that's still currently underway. In this piece of work, we were wanting to understand the way that intergenerational cycles of disadvantage play out in the early years of the next generation offspring. So during that infancy period that we know is such an important, sensitive developmental period, how does that emergence of those intergenerational pathways of disadvantage occur during that early time, and with the goal of informing what is a very significant policy imperative around disrupting these cycles of intergenerational disadvantage. Here you can see just one of the factors that we were looking at, an aspect of the home environment of smoking in the home during the first 12 months of the child's life. And we've stratified the prevalence of smoking here according to parents' educational attainment before they transitioned to parenthood. So as they were coming to the period of their life when they were transitioning to parenthood, what were the educational resources in the family environment? We examined this across two different cohorts, one, the Australian Temperament Project Generation 3 study, and also the Victorian Intergenerational Health Cohort study, which has this long-term intergenerational perspective on health and development across generations, and this very detailed and nuanced perspective on that healthy start to life in that first 1,000 days. So we examined this both in each of those two cohorts separately and combining the data from these well-aligned cohorts so that we could benefit from that larger sample size, get that more precise picture of what was occurring. And what you can see as we estimated or generated these estimates is that overall, where there was lower educational attainment in the family setting, we were seeing a much higher prevalence of smoking exposure for the child as compared to, for example, where there's a high level of educational resources. So just one area where we were starting to see potentially this emergence of those inequities that we continue to see across the LifeCourse. What you can also see here, if we look at the estimates for VIX and the estimates for ATP compared to the combined estimate, is that, as you would expect, as we benefit from that larger sample size, the confidence intervals are narrowing in. And we can see that estimates were pretty similar in those two distinct cohorts. And so that combined estimate is also giving us a meaningful summary of what's occurring across those studies. So this giving us insights into that earliest emergence of those intergenerational pathways of disadvantage, and allowing us to be more precise and perhaps more confident in our study conclusions. But of course, as well as motivating benefits and those types of payoffs that I've canvassed, there are also challenges that come up in working in this way across multiple cohorts. And one of these issues that we've been thinking through and grappling with is that potential for new sources of bias to emerge as we undertake this work, particularly when addressing causal questions. And this is thinking that has been led by Marnie and Margarita in the CEBU statistical team, able to apply very rigorous methodological frameworks to thinking through these issues. There are the biases that can arise in a sort of additive way by drawing cohorts together that each have their own sources of bias. But there are also potentially those sources of bias that can arise from discrepancies between the studies. And this can make it particularly difficult to interpret discrepant findings across the studies. But what's been so helpful from this work that Marnie and Margarita has been leading is the way of positioning the target trial, or the imaginary RCT that would have so elegantly addressed the causal question that we're interested in, positioning that as an anchor point that we can keep coming back to in thinking through these issues. For example, in thinking through the target trial, considering what would have been the ideal outcome measure for that trial. If it was mental health, for example, would it have been a diagnostic interview, or is the focus more dimensional, and so of interest a symptom inventory, focusing on internalising problems like the results I presented earlier. This can give us that anchor point where, instead of comparing mental health measures between the cohorts each to each other, which can sort of get lost in an endless cycle of slight differences between cohorts, we can bring it back to this single target or anchor point to consider. So really fruitful, helpful and pragmatic way of going forward and grappling with these issues and recognising those challenges explicitly and minimising them wherever possible. Another challenge to this kind of work is logistical. And Craig mentioned this earlier, that there can be significant roadblocks to being able to grapple with the data from across multiple cohorts. But the LifeCourse infrastructure has been working to help to address those challenges, to minimise them, and to make it as efficient as feasible to work across cohorts in this way. So one of those roadblocks is knowing about data, knowing that they exist, and being able to find where there are complementary or aligned data elements across cohorts. One of the ways that we address this in LifeCourse, and something that I just keep coming back to as a researcher working with these data, is our advanced search function on the LifeCourse metadata catalogue. And that's publicly accessible on our website. What the search function allows us to do is to run a query about one or more data elements that are essential to our research question, and see and narrow down which cohorts contain this information. So, for example, here I was interested in which cohorts had data on mental health and behaviour problems during the middle childhood period, and specifically assessed using the Strengths and Difficulties questionnaire, which I use a lot in my research. And what I found is that there were 17 cohorts, in fact, that contained this information. And the search results allow me to unpick features of those available data, as well as the studies themselves. So making it much more practical and feasible to identify where that relevant data exists. Of course, it's one thing knowing about data, but as a researcher, I also need a straightforward, efficient process to be able to gain access to those data, and to be able to do so in a straightforward manner. And again, the LifeCourse data infrastructure is really vital in making this a feasible and possible option, research option. So we have a data access request system that can again be accessed publicly on our website, and any legitimate researcher can come and submit a data access request. And what's really important in the multi-cohort context is that I can, for a single project, indicate all of the different cohorts that I might be interested in accessing. For example, the COVID analysis that I showed earlier, I was able to submit one data access request form that incorporated 7 distinct cohorts. So you can imagine my time saving as a researcher, being able to submit that one request, rather than going cohort by cohort, undertaking 7 bespoke data access request forms, 7 slight variations on a data request form, very low value work from a research perspective. So making this an efficient and feasible thing to do. This is, again, openly accessible resources available through our LifeCourse website, and encourage any researchers who are wanting to work across LifeCourse cohorts, or indeed just within a single cohort, to be utilising this platform that exists. So coming to the end of my presentation now, and been around a few different topics and issues here, but a few takeaways as I wrap up. So our experience in the LifeCourse team, I think could safely say, is that we have seen significant benefits to being able to work across cohorts in some scenarios, and in particular the capacity to engage with research questions that otherwise we just wouldn't be able to progress research in that area if we were relying on any one existing cohort study. But the logistical and operational requirements for working across cohorts, finding relevant data, getting access to that data are quite significant, and we should be using as much as possible platforms like LifeCourse that are specifically and deliberately set up to try to reduce these barriers. There are, in fact, a wide range of different analytic approaches that we can use when we're working across cohorts and analysing data from across cohorts. And we've argued that it can be really beneficial for researchers to be explicit about what the benefits they're aiming for are, and can use this to justify and inform their selection of analytic approach, for example. So being really explicit, including in that paper write-up, as to why we're moving into the multi-cohort space for a particular research question. Of course, no easy answers in anything that we do ever, I don't think. And there are also challenges that arise in working across cohorts from a conceptual and from a scientific perspective. And these also need to be recognised and carefully managed and thought through, including with statistical partners, as we've found extremely helpful in the LifeCourse setting. So thank you so much for coming along today and hearing from me. There's a few of our key papers there that might be of interest to follow up. But I'll now stop sharing and happy to take any questions.
Thanks, Meredith. That was a beautiful presentation and such a wealth of information provided to everybody. We're just putting our virtual hands together for you for that effort. So thank you very much. We'll open the floor now to questions from anybody who has them. Feel free to add them to the chat too, and we'll track that as well. But while you're thinking about that, I was just reflecting, Meredith, as you were talking, this historical journey that's involved in this. So as you said, we started this in 2013. At the time, I think there was only one major cross-cohort consortium sort of in our space, which was the Maelstrom Consortium in Canada, which I believe was set up 10 years earlier in 2004, so very progressive of the Canadians at that point. And at the time that we established this one, there was another competitor in the field, which was in the UK, which was the UK Closer Consortium that you mentioned, and their startup budget, I seem to remember, was something like £5 million. To get launched, which is a very different place to start from to the place we started from. But with the kind of right investments from people over time and from the MCRI and just the sheer passion and will and commitment of the people behind it, I think what we've produced here is just completely outstanding on the international stage in terms of the website that's been produced, and huge congratulations to you and Tahani and Anna and everybody involved in the development of that infrastructure. But now opens up all those possibilities that you've just shown us so beautifully in your slides. And you know, those possibilities are within generation, they're across generation, they're in specific subgroups, and they're also, they've even sort of captured a pandemic. So, you know, it really is quite an achievement. And it's interesting now to see the emergence of new consortia around the world too. And I'm thinking here of the EU Child Cohort Network, which was, I think, established in 2020. And then one that Margarita alerted us to just the other day, which is a new French consortium of cohorts. So I think we'll see more of these, and it's really wonderful to have been in such a leadership position in the development of them too, and seeing all those resources referenced. But that was just a reflection. Thank you very much again. Are there any questions from anybody? Any burning questions people would like to put to Meredith